start broadcast, so attendees will be piling in.
Mallory, you've pressured him into activating his camera.
Yeah, I'm trying to fit in.
You always fit in, Brian. All right, let them in, Mallory. Let's see who we have here. Ann Dahl. Hi, Ann. Connor. Good to see you, mate. Jean. Welcome. Jennifer. Jenny. Jerry Overton. John. It's in for his second webinar of the afternoon. Let's see, who else do we have here? Jenny, Julie Buckingham. Hi, Julie. Kyle, welcome. Lance, must have been 2 hours since we spoke last. Liz, good to see you. Lori, welcome. Paula, always nice to have you. Excellent. Well, we are right on the hour, so we're going to go ahead and we're going to get started. Let me just get acclimated here. All right, so on behalf of the Citizen CPR Foundation, we welcome our champions. We have 2 excellent guest speakers lined up for this month, and we will provide an introduction shortly. As a reminder, we're going to keep your microphones muted, and please share your questions and comments using the Zoom chat function as we look forward to addressing them after our guest speakers have finished. We'll entertain the idea of unmuting folks as well, but we'll see how that goes, okay? Let's get underway. My name is David Hiltz. I am the director of the HEARTSafe program, an uncompensated volunteer for the Citizen CPR Foundation. We're going to skip roll call today. In fact, I'm probably going to end up eliminating this slide for next month and moving forward because we're actually ending up with an increasing number of people participating on the call. I do see a lot of familiar faces on the call today, as well as some new folks. And I think you're going to be very pleased today with our 2 presentations from our guests. Just a reminder, if you have announcements that you'd like to make in this forum in the future, please pop me off an email in advance, and I will make announcements for any programs or exciting news that you'd like to share with the group. I'm not sure if the folks from Montana are on the call today, but wow, I mean, great job in securing funding from the Helmsley Foundation for equipping every single patrol car in the state of Montana with an automated external defibrillator. So bravo. So our guests today, as you know, every month we endeavor to recruit an expert to discuss critical subjects and innovations related to improving outcomes. And this month, we are absolutely delighted to have Dr. Brian McNally and Dr. Mike Levy on, who will discuss the topic of out-of-hospital cardiac arrest registries, how they enable communities to compare patient populations, interventions, outcomes, and with the goal of identifying opportunities to improve quality of care and outcomes. So I'm going to take a moment here to swap out slides and give control to our first speaker, Dr. Brian McNally. So let me stop the share. Brian, you should be ready to go.
Okay, I'm going to pull up my screen. Thanks, David. And can you see what I hope you can see?
Yes, we can see.
Okay, great. Well, thanks for the introduction. I recognize a number of familiar names on the call, and great to be co-hosting with Mike. I don't really have any conflicts, but I will acknowledge that I am quarantining in Maine. Mike's on the other end of the universe up in Alaska, which I think just if you live there, I think you're automatically quarantining when you live there because you're so far away from each other. But I'm going to talk about CARES today and kind of give big picture. I know this might be a little review for some folks, but David basically asked me to talk about measurement and the value of registry, and I think Mike will give a great example of experience as an end user and state medical director of how they've used CARES in Alaska. I don't know if Jenny Shin, the state coordinator, is on the call, but obviously they've worked together very closely, and it's great to partner with them. They're one of our original CARES sites. But the first slide here really kind of sums up what we've been doing from the beginning. We had to come up with sort of a mission and vision statement a couple years into the project, but really from the beginning, we've been focusing on helping communities to measure standardized outcomes for out-of-hospital cardiac arrest, and to use that information in a report format to better understand how to move the needle at the local level, at the community level, and hopefully to improve survival. Give me 1 second here. I'm trying to, oh, here we go. Got my controls. This is the current state of affairs with CARES. Where you see green is where there's a state coordinator. I know there's a few state coordinators that might even be on the call today, but the idea is we grew over time to allow not just individual communities to come on board, but where we have a coordinator to try to bring on and mature a state over time with both EMS contributing data and hospitals. Those are sort of the components. We pull in dispatch data as well, but the idea is to help as many communities come on board. Our vision is obviously to work with hopefully all 50 states, and we've had conversations in the past 2 years with Health and Human Services about trying to move in that direction and move from current state to getting 28 states to try to move to 50, and again to focus on improvement activities. As you can see here, there's been growth, as I mentioned earlier. Actually, I guess I've got this slide 1 year late, but 2019, we had over 100,000 records collected. This represents currently about a 45% of the US population contributing data, catchment area about 144 million, and obviously a lot of hospitals and EMS agencies that are on board. The state coordinators are the engine behind most of those communities, but then we have individual communities that where we don't have coordinators that we work with directly. I think some of this may be obvious to most on the call, but I think it's important to recognize why should you collect this data? Well, we know there's very few things in medicine where you could double survival by having a simple intervention, and out-of-hospital cardiac arrest, it's one of those cases where we know time matters, and the community obviously getting involved makes a big difference in advance of train rescuers arriving, often several minutes later in the best case scenario. There's obviously a big difference between an unwitnessed cardiac arrest and a patient that presents in a non-shockable rhythm compared to a patient that collapses in front of a bystander that presents in a shock rhythm and has an AED applied. And suggesting a bystander witness survival rate in CARES national data today is about 33%. So your 1 in 3 chance of surviving that scenario. Bystander CPR by itself can double or triple survival. So again, simple interventions that make a big difference. We know the biggest predictor of survival for this event is the care that's received prior to arriving at the hospital. Obviously, hospital care is very important, but if you have return to spontaneous circulation, aka a pulse in the field that's sustained before you arrive, that is the greatest predictor of ultimately leaving the hospital. You have a 35 times greater chance of leaving the hospital if you have ROSC compared to not having ROSC. And really this suggests this is where often the case is determined. Obviously, the care after makes a big difference as well, but it does not make up for the lack of intervention in the field. And I think this is not new news. This has been around for a while. There's obviously data before. This is an article from for those that may remember, the Opals trial back in 2004. This is the same year CARE started. So, recognizing that BLS and community intervention, those first three things in the chain of survival, have the greatest impact in terms of determining the likelihood of that patient surviving to hospitalization and hopefully getting home and being neurologically intact. Early access, early bystander CPR, early defibrillation. ALS care is important, of course, but did not really seem to have the same impact. Obviously, coming later in the event, drugs and advanced airways really have not shown the same benefit as those initial steps. So fast forward to the more recent data, 2018, from the Paramedic 2 trial out of the UK. This was randomizing for epinephrine. At the end of the day, they did a really great job of, studying giving a patient placebo versus epinephrine if they did not initially respond to resuscitative efforts. And in the end, they found that there was slightly greater chance of survival in those that got epinephrine, but not with better neurological outcomes. Probably the most important thing out of the study was, again, the basics make a difference. What's called number needed to treat, which is essentially how many patients would you need to treat to have one additional survivor. For epinephrine, you would have to treat 112 patients to have one additional survivor giving epinephrine. You'd only have to treat 11 patients with early recognition, calling 911 and recognizing the event early to make a difference in one additional survival. 1 in 5 for bystander CPR. I'm sorry, 1 in 15, 1 in 5 for early defibrillation. So again, it's the same information we knew almost 15 years ago, but telling us the basics make a difference. And kind of wanted to, keep it short, but I wanted to give you an idea. We're looking at big picture. We give out, each community that participates, each EMS agency and hospital has access to their data. We have developed standardized reports. Once a year, we go through and making sure that we provide an annual report. Each of the state coordinators is really involved with making sure every community gets access to the report from the calendar year, but they can log in and look at any time. We also have the ability to look at a snapshot of data, and we've looked at the data more recently from the last few months, obviously trying to look at the potential impact of COVID-19. And I just wanted to show you, we looked at last year data. These first two slides are through April. I'll show you slides, the rest are really through May, but showing etiology changed slightly. And again, this is representing close to almost 45 or 50,000 patients in each data set. So large numbers. There's a slight difference in coding of etiology, which we know can be challenging. A slight decrease in cardiac etiology, looking at the more recent data compared to last year. A slight increase in respiratory etiology, a slight increase in overdose, greater number of cases that are coded as other etiology. So again, not terribly different, but looking at data from last year, month to month, we don't see a lot of variation is what we expect. You might see some seasonality, right? When people are more likely to be outdoors, we might expect, of course, more public arrests. We might expect to see potentially more shockable rhythms if people were in that outdoor environment. But again, across the board, month to month, not a lot of variation. From top to bottom, you can see the bystander CPR rate's pretty steady. The green line is the termination resuscitation rate being pretty steady, and then maybe a slight upward of those patients presenting in a shockable rhythm, those patients having a public arrest, and those patients getting public access to fibrillation. This was 2019. We look at 2020, we can see some differences. The bystander CPR rate by itself, again, remains steady. That doesn't seem to change much. The green line is the termination resuscitation rate. There's a big jump. And we believe a lot of EMS agencies, though they've likely had protocols in place for a while, began to be more rigorous in terms of making a decision about ending care in the field if it was clinically indicated, then transporting to the hospital. So almost a 10% jump in just a few months' time. And then looking down, a downward sloping of the number of public arrests, the number of patients presenting in a shock rhythm, and then that bottom line significantly dropping off, the number of patients getting public access defibrillation, almost a third from the peak. So again, this is preliminary data. It's not complete, but it gives us a snapshot of kind of what's going on, and I think a better understanding of how a registry can help a community with quality improvement. But from a surveillance perspective, we also can have an understanding how resuscitation practice may be changing as a result of, obviously, the pandemic. Just to look a little bit more deeply, when we tease out bystander CPR rate, we could look at those patients that are getting bystander CPR in the home versus those outside the home. And this is 2019 data. Again, seems pretty straight. The top line is those that are getting CPR in the home, which there's maybe a slight word upward for a public arrest or public CPR as you move into the spring months. And then looking at the more recent data, you can see residential CPR is slight uptake, but more or less steady. Public CPR outside the home has dropped, though it may look like it may be rebounding a bit. But the idea of being able to tease this out, again, you can see here, looking at the bystander CPR rate for 2019 and then 2020. So I wanted to kind of just give you a big picture. Mike's going to talk a little bit more about wearing a medical director hat for Anchorage Fire Department, obviously, and the state of Alaska as EMS medical director, and really understanding at the local level and state level how to use this data. I think that's really where the rubber hits the road, in my mind, where people are making decisions. Measure it, step one, looking at your data, step two, acting on it. Mike's acted, and he's going to share his experience. So I'll end there.
Well,
Yeah, Brian, if you could stop sharing, and then Mike can begin his share.
Absolutely.
Thanks,
Let
Nate.
me stop share. That's it. There we go.
let's see if the magic works today. Let's see. Share screen, share screen. Did that share okay? All right, can you see my presentation?
Yes, it looks great. Thank you.
Well, fantastic. If it looks great, let's stop there. Hey, I want to thank Brian for a typically great presentation, and also Brian and his team, Ali et al., and all the great things they've done to allow us to participate in CARES and the benefits we've had from that. I want to not forget my disclosure, which is I do have a business relationship with Stryker Emergency Care. And I want to thank the Citizen CPR Foundation, David and all, for having me here. I also note that the participants in the in this meeting are basically all of my mentors and people that probably some of these slides came from. So I'm humbled and always happy to see you folks' name out there. So keep me honest. One last thing before I go on to this deal is that I kind of double booked myself. I forgot I had tactical EMS training today with the SWAT team. So I actually had to run over from the shooting range to here. And in terms of separation of people that Brian was talking about, I just came out of, we're doing extrication of hostages from school buses and city bus was the scenarios. So I've been packed into a bus unmasked with about 6 or 8 tactical guys kind of sweating and the like. But the most exciting part of that whole package was the school bus had a nest of hornets in it. So we had not just a bunch of these little hopper rounds going off, but the hornets were more dangerous than flashbangs and everything else. Do a lot of fun things. Okay, so coming back to this, I wanted to just talk about some of our practical experience we've had up here. The folks that I see on the program here have seen me talk about this before and are well aware of the geography. The geography of Alaska, based on the maps we've seen in school books and the like, with us tucked in nicely down there at the bottom, don't really translate to the reality of the size and scope of Alaska's geography. And it's a third of the landmass of the entire lower 48. But up here, as Brian pointed out, there aren't that many of us. There's about 700,000. And I guess if the economy keeps doing what it does, we'll have the last person turn the light out on the way out. But we are a big state and we're not heavily populated except in our urban areas, which pretty much look like most other urban areas. The thing that sets us apart is our roadlessness. And so when we buy these expensive GPS packages on our cars, for us, ours say turn right or turn left. We don't have that many roads up here, and that really does show the extent of roads. If you can see, for example, the one brilliant thing we did do is to not have a road to our state capital, so we can isolate those people down there without worry, especially when the planes aren't flying. But overall, the expanse of Alaska is uncovered by roads. So we are widely separated and do require that to get people in and out of an area, that it requires literally dog sled, boat, airplane, helicopters, what have you. Also, the hospital system is somewhat limited as well. Of the tertiary care hospitals are basically centered in the center of the map there where all of the lines converge, and that's South Central Alaska, Anchorage area, where the PCI hospitals exist, except there is one up in Fairbanks, and where most major medical care occurs. And smaller hospitals and regional clinics exist out all the way up to northern Alaska, up to Nome and Barrow area, and to where we have the oil fields at the very top of the map there, all the way down to the peninsula, where those patients often become more affiliated with the Seattle area for healthcare sometimes than up further. And then we go all the way out onto the Aleutian Islands there, where certain politicians can even see Russia. We sometimes get patients back and forth like this. We typically have a hub and spoke approach. So you saw the vast distances we cover here, you can't really do in other ways. And the landing strips and the like we go to get patients out who are having acute coronary syndromes requires typically that we come in with smaller planes, such as this fixed wing Cessna Caravan, and then we find ways to get the patient back and forth. This was not a staged maneuver. This is pretty typical for throwing all the equipment on a sled or something like that, and then throwing it behind a snow machine to get to people. And then we move to an area where we can get jets in and then move the patients by jet to tertiary care. In terms of what we can do with this information, Anchorage has just really enjoyed the benefits of good relationships. We've been involved in the CARES project for many, many years. I forget how far back it goes, but I think it's not long after CARES was established. But beyond all the great relationship we've had with CARES, we've had a great relationship in particular with Seattle-King County and the entire group of just unbelievable folks down there. We were able to become associated with the Heart Rescue project, which was another huge benefit to our state. And we always will feel a tribute to the group that brought us in down there, many of whom are on the phone today. I co-authored with Jenny Shin, again, another person to whom I owe many things, to try to convince the state that there was a reason that we should move from just having Alaska, Anchorage, Alaska being covered with CARES, and find a way to move this out through the state. We had been working under the aegis of the Seattle-King County crew and the Heart Rescue, and we were able to bring some of this out to the state, but we were really never paying the freight, as it were. And so with Jenny's authorship on this, we were able to bring forward through this epidemiology bulletin the actual benefit that could accrue from having this kind of information available to the state. So these are the areas, the major population areas with hospitals that we brought on through, again, efforts that centered, again, pretty squarely on Jenny's shoulders, but we all put a little bit of effort into this. And we were able to bring up a situation where we were basically able to cover about 80% or higher than that of the entire population of the state by the efforts that we went on with regard to the CARES. And when we look at our rates, overall, despite everything else that goes on in Alaska and the distances involved, it's nice to see that by and large, Alaska stacks up pretty well. Now, there's a certain skewing of these data because of the fact that half the population of Alaska lives in Anchorage. And so a lot of these data do follow the trends of Anchorage, which has been in the, it's been a system that performs fairly well with regard to cardiac arrest outcomes. but nonetheless, we're able to bring compelling information forward, not just we think, but we have the information. We brought this forward to the state leadership. And with this, we were able to leverage this into funding for CARES for the state within the past couple of years. So that's been a huge benefit to us. And really nothing speaks like data. Again, these are more data coming out of our initial paper, but it gives us an opportunity to have a benchmark and to see what we're working against and working towards. What I wanted to point out too, and this I'll zoom in on this slide a little bit, but this is the CARES dispatch module, which we mocked up within the Anchorage Fire Department so that as we were getting information to enter into the CARES module, we're able to also have that for our own internal use. And with this, our crews managed to put the audio clip of the cardiac arrest embedded in this file so that when I go back to review it, I can just click on that hyperlink there and I can hear the whole audio that went on. Additionally, in Anchorage Fire Department, we try to hot wash these, do a review of them while the shift is still on as time allows. And that's been a big step forward too. And I have one other larger communities, a peace app that I'm in charge of as well. And we've been working on instituting this with them. So these are very nice for us to do, and it's very achievable. It doesn't require a lot of extra overhead for the dispatchers and provides that important information for what is certainly, if not one of the most critical parts of the whole infrastructure for cardiac outcomes, and that's telecommunicators CPR. Another thing that we're able to do, which I just did recently, and again, I couldn't have done this without Jenny Shen's help, but there was a controversy, and is a controversy that's arisen in the state. I've wanted us to move more aggressively to run the pediatric arrests on scene based on some stuff coming out of Florida, but also from the common sense of we seem to do our best resuscitations in place as opposed to moving while we're still resuscitating. And there's a little bit of controversy about that. One part of the controversy in our state was that there's unfortunately so much child abuse that a large proportion of the pediatric deaths actually can be attributed to about 10%, it sounds like, can be attributed to some type of maltreatment. And as a consequence of that, there was this feeling that the children should be moved even before they're fully resuscitated to a higher level of care. I was able to bring these data to these folks, who are folks in the pediatric world, to ask them how they thought that was going to improve anything, honestly. So when we look at these very bleak numbers in terms of the outcomes at different age groups for cardiac arrest in pediatrics in our state, to me, it's kind of this, I attribute to Einstein, correct me if I'm wrong, but the idea of doing the same thing again and expecting a different outcome. And this, having these data as opposed to us all saying, yeah, but I had this one great save, this kind of thing is much more compelling. I think everybody would agree with that. So that's still a work in progress for me. These are just the data that we've looked at. If we look at Anchorage's data just real quickly, we see that we do pretty good, and we do this number of resuscitations, which is part of a day in New York City, and it's a year for us. But it is our denominator. Now, again, you see our survival rates there. When we look at our other systems, for example, looking at some the smaller systems down on my other systems, these folks seem to do a good job resuscitating, but they end up going to people who are well and truly Wizard of Oz, crushed under a house, dead. And so even though we have a few number of attempts, the outcomes are not good. This gives us something to go back and compare against. If we look on the other hand at another group, and let's see if I didn't advance that correctly. Oops. Let's see, did I do that wrong? Yeah, so when we look at our other group in that same general area, they had this number of resuscitations attempted, 19, and of the witnessed VFs, they had all of them survive. One thing I like to point out to my groups is that we don't really want to concentrate on the percentages too much. We can look at Anchorage's numbers and we can say that there's this percentage and it's based on a larger number. We can look at this group's percentage and say they are the best resuscitators on the planet this year. And we can look at the other group and see that they're the quote worst resuscitators, but these aren't really true statements. These are things that allow us to go back and look and see what happened, and we have these data to do that. It provides an opportunity for us to improve. My feeling in the situation of these folks who are either great or not great has something to do with them, but has a lot to do with the geography. And I think until we fully are able to leverage the full opportunity with telecommunicators CPR for these rural areas, that's kind of the place where I live, the fact that it takes us 15 minutes to get to some place and that people do not cluster in small communities, but they're spread out, until we can leverage the telecommunicator CPR and also getting other people who are nearby on scene, I'm not confident we're going to significantly move that needle. So I really think that the good news about COVID has been that everything that we said couldn't be done because of all the political encumbrances and the like, all of a sudden, we were able to turn the ship really quickly. I think this is a good opportunity to further, look at that opportunity in terms of using remote technologies that are already pretty well, fleshed out, and start using them just much more robustly. Get our telecommunicators involved in helping leverage their skills to more people. I think that's going to be the next big thing for us. So with that, I'm going to close out and hope that you're still with me there and that there'll be some questions and some answers to this. Thank you.
Yeah, so Mallory, could we try opening up the mics for a few minutes and see if we can field some questions voice to voice? I'd ask that if you are not speaking, please keep your phone muted. Mallory, is that possible?
Yeah, let me go ahead and get the questions going in the meantime, since we have a couple that have already been submitted, and then I can work on that.
Thank you.
Yeah, so our first question that came through is for Brian, and the question is, what are the primary barriers to adding new states?
Oh, that's a great question. Well, I'll say this, what we've learned over time is every state is different, of course. I think sometimes the challenge is trying to figure out, even when there's a desire, and let's say there's the resources to move, is trying to figure out where's the best place to house a coordinator. That can sometimes be tricky, sometimes not. Certainly it's taken longer to figure out, should this be somebody that's, their home base being at a hospital, because we have hospital-based coordinators, we have state-based coordinators from government, and then we have nonprofit. Academia often is probably our biggest home. So sometimes it really comes about as to, the actual HR home. Sometimes it is a resource issue in terms of trying to find the funding for the coordinator. Those are sometimes the biggest obstacle, might be the word, or the thing that sometimes takes time. The biggest issue is if there's the desire and there's a champion, even if it takes 2 years to get things in order, we're always, we always recognize when things are right, they will happen, and trying to rush things doesn't make sense. But a champion is often the most important thing to get things started. The resources and the HR home are the things that sometimes add on additional time.
Excellent.
Great.
So I believe Mallory has enabled everyone to speak.
Yes,
We'll
so
need
I'm going to go
unmute
ahead
yourself.
and keep going with the questions that have been submitted, but I would like to let the attendees know that you do have the ability to speak. You are all automatically muted, but if you choose to ask a question when we open up the floor, you would just go to the bottom left-hand corner and unmute yourself. In the meantime, this question was submitted for both speakers from Julie, and she's asking, unlike EMS, public safety communications, and TCPR does not have a uniform reporting process. This creates the normal problems that come with a lack in standardization of data collection or even definition of data criteria. It feels like it's time that we have a Stein set of guidelines for TCPR. Would you agree? If so, how do we make that happen? This question is also in the chat box in case I lost you at any time, speakers.
I'll let Mike, I mean, I could take a first crack. Mike is an end user, so I think he can show you, what he was showing you before was their data entry page and their ability to enter into the CARES telephone CPR module. We've created this, and the question is correct. There's not a universal standard internationally for telephone CPR, but I think we have a pretty good start, for the elements. When you look at the more recent recommendations that have come out in the last few years from American Heart Association, we have the ability to answer those what we believe are those most important questions. Number one, was the dispatcher able to recognize the caller type as a true cardiac arrest? Yes or no? What was the time from call receipt to initial recognition, from call receipt to initial instruction, from call receipt to initial compression? So those are the intervals that are at least recommended that systems, collect. We recognize a lot of communities, there's a high burden to be able to go back and abstract that data from a 911 tape. But I'll let Mike answer because they've been doing this consistently. And I do agree, there's definitely room for improvement and refinement, but I think there's been a lot more acknowledgement in just the last few years about the importance of these metrics and providing recommendations for goals in terms of those intervals.
Well, that's well put, Brian. I got to tell you, this call has a bunch of ringers on it, and not the least of which is Julie, who's one of my mentors.
I mean, David totally set us up on this one.
So I don't know that I can answer for her, and if she's unmuted, she might want to simply help. But I would just say that what I feel she's alluding to is the fact that we do have the rough parameters for important metrics with regard to telecommunicators CPR built into CARES at this point in time. But in terms of moving this to the next level, I think there's much more that we can do to help facilitate best practice with regard to telecommunicators. And I think having a standard for that would help move this out of a kind of a proprietary mode into a more robust and more universal mode.
Yeah, and what I can add to that's a good answer is we've communicated and have a very good relationship with John Kramer and his team at NHTSA, and obviously Clay Mann and the NEMSIS group. There are currently no NEMSIS standards for telephone CPR metrics, but we've suggested to try to move in that direction. We've just harmonized our essential fields with the next update 3.5 version, and NEMSIS CARES essential fields and NEMSIS are harmonized. It took a long time to get there, so we're very excited about that. For 3.6, which will likely be further down the road, we've already they want to harmonize our supplemental fields, which would include the telephone CPR metrics. So I think there's a pathway to get there with NEMSIS, but we can't wait for that. And I think if there was a Nutstein group that wanted to look at this more critically, I think that's a step in the right direction. But I think the opportunity and the other opportunity has been working with industry partners. We're currently working with industry partners that are in the dispatch software space about trying to decrease the burden in the abstraction process.
Yeah, this is sorry, Brian, you cut out. This is Julie. I just wanted to add, speaking about standards, Nina is actually writing an ANSI standard for TCPR right now. And performance metrics is one of the areas that we'll be making a recommendation for in that standard. But having the ability to work with so many systems and seeing really great disparity in how data is collected around TCPR, where you have some systems like King County who extract a substantial amount of data around those calls, and then some that only collect a couple, and then everything in between, and variances in how it's even being defined. What is identification? At what point does that happen? At what point are we identifying that chest compressions began, and so forth? So if anyone ever wanted to take this effort on, I would love to be a part of that and help out. I think that, you know, it's time that we start getting a little bit more alignment with this data if we can.
I think you've made great suggestions, and you're definitely way ahead.
So we had another question submitted before we open up the floor for Dr. Levy from Pam. What was your bystander CPR rate for the last year on the slide that you shared?
You're muted, Mike.
Thank you. I think it was about 77%. I think Pam brought me up to speed on that.
Impressive.
Okay, I'm not seeing any more questions through the chat box.
Can I come off mute for just a second?
But I definitely think this is an appropriate time to open up the floor. Just utilizing proper Zoom respect if possible, please.
Pam's trying to get in. Go ahead, Pam.
Okay, Mike Levy, Dr. Levy, sir, that's pretty impressive. I know that you're a fan of telephone CPR, but do you really just think telecommunicator CPR is how you get to 77%? Because the rest of us aren't anywhere near that.
Well, yes, but I think it is, you know, honestly, I think there's telecommunicator CPR and there's telecommunicator CPR. So I think there's a lot to be said for, you know, phraseology, would you versus you will, in terms of working with people about doing CPR. There's always going to be issues. So if the 250-pound gentleman is wedged between the toilet and the wall, the, you know, frail 70-year-old wife isn't going to be doing CPR. And there's we have poor CPR that's done clearly. People that can't get off the bed, can't get to the floor, et cetera, et cetera. So there's always going to be some challenges, but it really comes down to, you know, breaking through, recognizing very early on through a simple process that CPR is indicated, being able to be tolerant of the fact that we will over triage to CPR and just dealing with that because the benefit outweighs the risk, I think. Then, you know, just being very, very direct and having people do CPR and tell them to do CPR.
Nice job. Thank you.
It's all on them, not on me, but I appreciate it.
You know, Mike is.
I installed. Your internet connection might be a little bit unstable, Brian. I don't know. You stalled.
I was actually impressed. You got a good signal from Maine in the beginning, but those satellites do move.
Well, Mike, while Brian's trying to come back, I have a question for Mike.
Janet, go ahead.
Is there one dispatch center for all of Alaska, or are there multiple dispatch centers?
Multiple.
Okay. Do you train them all, or are they? How are they supported?
So there's different types in the state. Again, the largest is Anchorage, and the Anchorage Fire Department is secondary to law enforcement, and we train them, you know, basically internally. This department uses criteria-based dispatch. I have another, probably the second largest in the state is another PSAP that I'm the medical director for, and that's combined public safety. So it's law enforcement. It has a lot of different hats that they wear. They do use MPDS, and Jerry Overton, apologize if we've transitioned to IAED, I think. I'm sorry to not get that right, but I'm so locked into saying those four letters quickly. And so we work with that product as well, I think, quite effectively. And but our dispatchers there are a little less, they've had a little less time under their belt with this, and they also have law enforcement responsibilities, including having a little earbud in to get the personal communications coming from the officers. So a lot of different challenges with different agencies in terms of effectiveness.
Who else is ready to unmute themselves with a question?
Hi, Brian. It's Paula Lank. Hi, Mike. Nice to see both of you from sunny Scottsdale. The question I have for you, Brian, is there any progress on actually establishing a national registry? I mean, you were working hard. The ROC data is referenced often. It's really CARES and ROC data still in the American Heart Association annual statistics. Is there collaboration planned or underway with the FDA on that topic?
Great question. Nice to hear from you, Paul. As recently as this morning, Ali and myself were on a phone call with contacts at HHS and discussing how to advance. We've had discussions now for the last 2 years. For those that know Admiral Giroir, the testing czar, who I think a lot of people may not have known until recently with COVID. He's the Assistant Secretary for Health, the number 2 person at HHS. He's taken an interest as a result of, after the IOM report and this cardiac arrest collaborative, they were able to get an initial meeting through both Red Cross and AHA having called the first meeting. And we've met now several times and had teleconferences. We're trying to get in front of him again. Obviously, he's pretty busy, but we're working with his chief medical officer about trying to advance getting all 50 states on board and having a public-private partnership. That's been the discussion that we've been having. What we're trying to use, some of the slides I showed you today are slides that we've shared with them of, having real-time data, modernized data infrastructure, which CARES, qualifies for being, a good example of how you can do surveillance electronically in this country and have data for real-time understanding of collecting data today to figure out what to do tomorrow. So there's been a lot of discussion. We're trying to focus on the funding piece and potentially the opportunity for more recent dollars that could support the initiative, including COVID funds to allow the 2 goals that the Admiral is focused on that we are aligned with is getting all 50 states onboarded. So it's truly a national registry. And he has a goal in a 5-year period to advance survival for witness cardiac arrest by 50%, which, is pretty ambitious. Yeah. But it's really a measurement and improvement focus. It's not just getting those states to participate, it's trying to move the needle. So we've really tried to, acknowledge the need for not just funding, but also getting CMS. And there's been discussions about this already to tie EMS payment to data collection. There's sort of a perverse incentive right now. EMS is reimbursed based upon whether they transport the cardiac arrest or not, which is not always the right thing to do, of course, for the patient. You should be paid the same. And that's one of the discussion points we've had is trying to standardize payment tied to care, not tied to transport, but add in, if you're going to reimburse at that standard rate, whether you transport or not, there would be a request, an incentive to get reimbursed at a higher rate. You would need to provide data. So there's been a lot of discussion. We're hoping that, this window between now and the end of the year, and even before, the election, when there might be transition in folks that we're talking to, trying to make things happen. So that's sort of that's maybe a quick summary of what's gone on the last 2 years, but really trying to make it a public-private partnership. CDC was the first 8 years of CARES, and since then it's been private funding from Red Cross, AHA, and subscription model. We would like to see the HHS, support their 2 goals with the resources that are needed to get all 50 states onboarded.
That's great. Thanks, Brian.
Sure.
David, I actually had a question. If I could ask, I'd like to actually call out Brian and Tom Ray if possible.
Yeah, you
And
can call out anyone you like.
Dom's been waiting for your call, David, or Mike.
I bet. I just was curious if you guys had thoughts about, the COVID pandemic. Your slides were very interesting. I'm curious if there's concern that our resuscitation rates overall are going to show a dip, participation from public show a dip. If this is going to significantly affect how we interpret cardiac arrest data and cardiac arrest resuscitation, and whether CARES might help normalize this dip by at least letting us know what's changed from past to kind of our present.
Tom, do you want to go first?
Sure, thank you. It's great to see everyone engaged and involved. This is a great forum. So Tom Ray from King County. So I think you ask a very complex question, which will require the type of data collection that CARES does really to try to address. So I think there are a lot of moving pieces here, and some of it is the risk of cardiac arrest going to increase? Perhaps because of COVID, but perhaps because people aren't having their other symptoms attended to. So I think that's part of the puzzle. And then of course, the health services response in the community by law enforcement, by EMS, all these things may be affected all the way down the line through the hospital. I think CARES will be in a good position to help us understand some of these dynamics and make sense of it and hopefully do better as we go forward. That would be my short answer, I think.
Yeah, I agree with everything Tom said as usual. I think there's, the direct effect and likely the collateral effect of COVID, like we see in the hospital as well as outside the hospital. More patients calling that would normally come to the hospital that call EMS and now are afraid to come to the hospital. How many more are not calling EMS? And I think that's been the question that a lot of people have asked. And then of course it goes back to, well, how do you find that data? And, we're obviously focused on cardiac arrest. We don't have STEMI data nationally, right? We don't have stroke data nationally. We have Coverdell Stroke Registry, which is a good way to get a better understanding, but it's multiple states. It's not more than 20. And I think it begs the question of, why there needs to be greater investment in public health infrastructure. That's what the testimony just a week or so ago of a number of the coronavirus task force members before Congress. I wrote down the words and shared them with our HHS colleague after we met, which was data modernization, real-time data collection to have real-time decision making, and really surveillance. And if you don't have basic information, it's really hard to understand what's going on. And I think that's part of the challenge is, we're not collecting, of course, those patients' resuscitative efforts are not initiated. We're not collecting all deaths. If you want to get that information, right, there's a lag. And then each state, there's maybe differences in how that data gets collected nationally. So it's really hard to understand, local or regional data is probably more helpful. But that's what we've tried to show with CARES is we've got 45% or so of the population contributing data this year. Here are the trend lines. Here's what was going on last year. There clearly seems to be a direct impact and likely an indirect impact in the care in resuscitation practice this spring. And there seems to be potentially an inflection point, and hopefully things will improve. And that's what it looks like, in terms of the public bystander piece. The AD piece has dropped off precipitously by bystanders, and we'll have to look at next month to see if there's sort of a rebound. But it's I think this is why this data is so important. And, at the local level, it's quality improvement. At the larger level, it's really understanding what's going on with practice. And clearly some communities are going to be impacted much greater. For those that know, Paul Chan is working on a study right now. We're linking county level data in CARES for the first several months of the year, and comparing with last year and linking it to COVID data that's available. How good that COVID data is, I think, is a good question, but trying to begin to look at those counties that were impacted even greater, or even those urban centers versus rural, what is the difference in disparity in outcomes? So it'll be interesting to see what we learn from that analysis. But we're really trying to drill home this point at this moment in time, which is, this is built, it's working. We'd like to get the rest of the country contributing data, and how important this data is to try to understand what's going on. When you don't have it, you really are kind of navigating in the dark.
Dave, I would just follow up with one other comment in response to Dr. Levy's question, which is, the HA and others, the European Resuscitation Council, have come out with interim guidelines about how to treat patients during the COVID era. And I think they reasonably acknowledge the gaps in information, which are quite substantial, right? And so they're doing their best in really what's an information vacuum to try to provide reasonable guidelines. They're also, I think, erring on the side of safety, and I understand that perspective. But I think there's a need to really drill down and try to answer some of the gaps. Like, what are the risks to the bystander in the community? And that depends in part on the prevalence of COVID in that community, and how likely a person with COVID is to transmit based on compression-only CPR or whatever the intervention might be. So I think there's a lot of important questions that are outstanding that we need to try to address. Not going to be easy, so that we can provide sort of confident directives to bystanders and laypersons. They are clearly a key, if not the key, to improving survival. Early intervention makes all the difference. And so I really hope we can make some progress there, because right now there's angst, and where there's angst, there's reticence. And where there's reticence, there's no action. And it's a consequence that persons die when maybe that they might not have had to. So there's a lot of work to do on this front of informing best practice. I'll stop there.
Agreed. We've got a few minutes left. I'm just going to share my screen here. And we've moved through the questions and answers, at least for now. Brian and Mike and everyone on the call, fabulous, right? Just an incredible discussion that has far exceeded my expectations when I initially called Brian to set up them as guests. So there's a great deal of work to be done. I mean, pre-pandemic period, there were issues, and those issues have become exacerbated and even bigger in many cases. The reluctance among bystanders to step in, even when it's a family member or someone who's known to the witness. So there's a great deal of work to be done. And more than we could solve on a 1-hour virtual webcast, right? But I see these monthly webcasts as being part of a collective effort to learn more, and by learning more, develop revised and improved strategies, because clearly community and citizen response plays an enormous role here. And so I see, creating favorable outcomes is like baking a cake, right? You have to have all the right ingredients and the right amounts, mixed in a very certain and appropriate way, baked at a certain temperature for a certain time. And if any single piece is missed, you know what happens, right? The cake doesn't rise. This is one of the reasons I'm not a baker, right? But we do have a great deal of work to be done. This has been extraordinarily beneficial for me. And what I'd like for people to do in these closing minutes is that, because this is only our third monthly webinar, Champions webinar, please go ahead and list in the chat function, you know, was this beneficial? Was this worthwhile? Did you learn something? God, it was awful. David, you need to do something with your hair. Let us know how we're doing. And to that end, you know, I have my own notions about what could be a priority subject for next month. But for those of you who know me, you don't want me making the decision. Weigh in, let us know your opinion, because we can have, you know, we can make a really high quality, you know, monthly effort. And again, Brian and Mike, Tom, everyone, thank you so much for, you know, your generosity and your passion around saving lives. And that's from me and on behalf of the Citizen CPR Foundation. So list any feedback, and then, you know, once you're done, you know, off to your next activity. But I'm so blessed by knowing so many of you and seeing some new people on the call. We hope to see you next month. And until then, stay safe and stay healthy. If there's anything I can possibly do for any of you to make your life and work easier, you need only to ask.
Excellent.
Thanks.
Thanks,
David.
everyone. Bye-bye.
Thank you.